as Abraham Lincoln quotes, "Next to creating a life, the finest thing a man can do is to save one." Namaste, we're back again with another episode of Resuscitation, the official podcast of the Indian Resuscitation Council Federation. Join in to get the latest from the world of resuscitation. This is Dr. Megha Venkatesh from Bangalore, and joining me is Dr. Manshir from Cochin as your host today for the podcast. Joining us today, we have three dignitaries from India and across the world. Firstly, Dr. Bernd Böttiger, President of the German Resuscitation Council, Professor and Head, Department of Anesthesiology and Intensive Care Medicine at the University of Cologne, Germany. He's been associated with European Council since the year 2002, served as the chairman in 2008 and currently the treasurer since 2020. Professor Böttiger brings with him profound knowledge and experience in critical care and emergency medicine and numerous scientific contributions in the arena of resuscitation. So we're privileged to have you today on our podcast. Your time and interest are deeply appreciated. Next, we have Dr. Rakesh Garg, Editor-in-Chief for the Indian Journal of Anesthesia, and he's also the Scientific Director of the IRCF. We also have Dr. Mukul Kapoor, former President of Indian Association of Cardiovascular Thoracic Anesthesiologists. He's also the member of Communication Committee of International License Committee on Resuscitation, ILCOR. Without further ado, let's begin today's podcast. Over to you, Dr. Manshir.
Professor Böttiger, it is truly a delight to welcome you to our podcast. You have more than a decade of published work in the field of resuscitation. I am curious, out of all the things, what attracted you to the world of resuscitation? What was your inner calling?
Yes, hello, and thank you very much for giving me the honor to be part of your podcast. It's a great honor for me. When I started as a young doctor in a community hospital, we experienced sometime a 40-year-old female with severe pulmonary embolism, and we have also diagnosed it. And then we decided to transport her to the next university hospital, which was 1 hour away by car. And we took her into the car, and we came only a few kilometers, and then she became a cardiac arrest. And my colleague resuscitated her for more than 1 hour without any success, and we lost this patient. We were all very negatively touched, and we decided next time in such a situation, we treat that patient by ourselves. And then I had the duty to come up with a plan, and I went through the literature and I analyzed all the literature on pulmonary embolism, and I have saw very few case reports on thrombolysis during cardiopulmonary resuscitation in acute pulmonary embolism. And we decided next patient we treat by ourselves. Several months later, a 60-year-old suffered from pulmonary embolism only 24 hours after surgery. And I was on call and I took her to the ICU, and after a few diagnostic measures with a typical ECG pattern, her hemodynamics deteriorated and she went into cardiac arrest, and I resuscitated her for nearly an hour without any success. And I was a little bit afraid of giving thrombolysis because this is more than 20 years ago and it was forbidden. It says in all the books, do not use thrombolysis during cardiopulmonary resuscitation. And nevertheless, we decided then to do this, and 1 hour later, after 1 additional hour of cardiopulmonary resuscitation, her hemodynamics recovered and she regained return of spontaneous circulation and survived. After 3 days, we could extubate her trachea, and she survived without any neurological damage. She was 60 years old during these days, and about 3 years ago, she died at the age of 90 years and experienced a lot of children, grandchildren, and great-grandchildren. And that was the start of my interest in cardiopulmonary resuscitation. And that was the start of a new therapy called thrombolysis during CPR in acute pulmonary embolism, which is now a worldwide recommendation since more than 10 years and supported by ILCOR.
That was such an inspiring story. It is also a perfect example of how you can turn a negative energy into something that's so positive. I was going to ask this question later on, but since you brought it up, there is something in your profile that caught my attention, and that was the use of thrombolysis during resuscitation for out-of-hospital cardiac arrest. Can you describe more about this work from your experience?
Yeah, we started with this case, and we experienced a similar case several months later, and we published these cases during these days. It was 30 years ago. And we get highly criticized because all the very experienced physicians said it's not allowed to do CPR and thrombolysis. Don't you know what is written in the books? And we said, no, we believe that this is a new and positive thing. And I have then seen in the literature some animal experimental studies showing that thrombolysis after cardiac arrest and during ongoing CPR was associated with improved cerebral reperfusion. And that was the point where I went to the Max Planck Institute for Neurological Research in Cologne and asked the director whether we can do some investigations on that. And then we did some experimental studies, and we confirmed that thrombolysis during resuscitation is associated with better cerebral reperfusion because cardiac arrest and CPR was inducing coagulation activation without adequate activation of endogenous fibrinolysis, and therefore having some kind of no reflow phenomenon in the brain. And we then confirmed coagulation activation also in patients during CPR in out-of-hospital cardiac arrest. So we draw blood from them during ongoing CPR, which was the first time someone did that in the world. And we published that in Circulation, coagulation activation without adequate activation of fibrinolysis. And then we did a large-scale European multicenter trial with more than 1,000 patients enrolled on the use of thrombolysis during CPR. Overall, it was not associated, unexpectedly not associated with a better survival, but in the subgroup of patients with pulmonary embolism, we saw a strong signal of improved resuscitation rates. And this was then confirmed by other groups in case series and small studies. And since these days, about 15 years ago, it is now a worldwide recommendation to use thrombolytics in patients with cardiac arrest due to pulmonary embolism, or where pulmonary embolism is highly suspicious. And it is recommended to use it. And it is also recommended to do CPR for at least 60 to 90 minutes because the thrombolytics need their time to solve the thrombi. And mechanical chest compression is also positive in big pulmonary thrombi, which has been proven by angiographic procedures, because then big thrombi will get into smaller ones, and smaller ones are much more lysable by thrombolytic agents. So I'm proud that we have established with this a unique therapeutic option in 5 to 8% of all out-of-hospital cardiac arrest patients.
One needs a lot of courage to challenge existing dictums and then do research on it and make it the new dictum. That is truly the essence of science. I can see Dr. Rakesh perhaps wants to contribute something to this.
So, Manchal, I think what Dr. Bernd Böttiger is coming up is a very good suggestion for all the resuscitation scientists in this part of the world also. And he's putting it that when we are doing a lot of resuscitation, anesthesiologists along with other specialty are coming together, we need also to have the same inquisitiveness for bringing these ideas into research. Because during the RECOR meeting, it is being discussed, and Professor Böttiger will agree to it, that each population has some demographic or genetic variation, in addition to the demography and maybe some amount of biological difference also. And this infrastructural, demographical, biological changes will mandate. And I'm really impressed with Dr. Böttiger's inquisitiveness in the beginning of his career, where certain things motivated him to bring certain things to the research. And I'm sure that the resuscitation scientists from India and various Asian countries will also look into this, that if the success rate of the outcome is not coming to the mark as compared to the Western population, do we need to have research in that area? And this is what even the Indian Resuscitation Council Federation is looking for, that the data that we are using should be applicable to the population for which a guidelines is prepared. And Professor Böttiger has very aptly, very correctly has put into this notion that we have to be bringing those ideas into the research and publish the data out of it so that we can create more guidelines. So this is Dr. Manshar. I just wanted to add it and appreciate his way of bringing the resuscitation science into the research, into the evidence, and then to the guidelines.
Much, and if I'm allowed to add, it sometimes big things for the world really start in small hospitals.
Absolutely, I fully agree, sir, because when we're talking of resuscitation, and we know that the majority of time, the cardiac arrest will happen in the peripheries. The patient may be brought to a small hospital with limited infrastructures. So we have to now put the patient from there itself. So even if the patient is brought to a higher center, he should be salvageable. So those initial moments is very, very important. And that's why the Indian Resuscitation Council Federation has been very proactive for layperson CPR in the form of compression-only life support. We call it as COLS, which has become a buzzword now in India. And probably you are right that if the initial resuscitation is good, probably the outcome of the patient becomes better. So all, even the small hospitals, peripheral hospitals, outside the hospitals should be strengthened with skills of doing CPR by all the paramedics and laypersons. You're absolutely right, sir.
Yes. So if you're a young researcher, keep challenging the boundaries. Only then you can advance science. So one of the things you have done a lot of work is in empowering school children for resuscitation. This is truly remarkable. The Kids Save Lives movement. What made you think children would be pivotal in improving the outcomes of out-of-hospital cardiac arrest? And when did this movement begin? Have you started seeing any palpable changes in the outcomes yet?
Well, what I would like to tell you is that after our experiences with thrombolysis during resuscitation, I was working for several years at the Max Planck Institute for Neurological Research in Cologne in Germany. And we tried very hard over years to find any drug or any intervention that can alter cerebral damage and that can enhance cerebral recovery after cardiac arrest. And we tried dozens of different approaches, and all more or less failed. And this was a very frustrating several years lasting experience. And then all of a sudden, we did some further clinical investigations in Heidelberg in Germany with the out-of-hospital EMS, Emergency Medical Service System. And we found that if the emergency medical service arrived within 4 minutes after the arrest, the survival rate was 3-4 times higher than if they arrive later. But we were all sure that emergency medical service cannot arrive at a patient all over the country in 4 minutes. And then we ask ourselves, how can we achieve an intervention within 4 minutes? And the only intervention that can really improve neurological outcome and can be achieved within 4 minutes is lay resuscitation. And the lay resuscitation rates during these days in Germany were less than 15%, less than 15%. And we were really thinking, how can we increase lay resuscitation rates? And then I met a young lady, 16 years old. She was trained from her age of 8 years by the German Red Cross in first aid and resuscitation. And I met her at a university event in Cologne, and she told us that she successfully resuscitated a 12-year-old boy in her school after he had a cardiac arrest with ventricular fibrillation. And that was one of the starting points where we then started to train school children in cardiopulmonary resuscitation, because we said then it must be like swimming or bicycling or playing an instrument. If you learn it before high puberty, you will never forget. And at the occasion of the European Resuscitation Council annual meeting, 2009 in Cologne, we trained 400 school children in the City Hall 2009, 15 years ago. And we have been visible in all news in the evening. And that was one of the starting points. And in the meantime, we know from data from Denmark and other countries, school children education in cardiopulmonary resuscitation is a major part of a whole mosaic, how we can increase lay resuscitation rates. And we know that with lay resuscitation, before the emergency medical service are arriving, immediate start of lay resuscitation, survival rates do increase by threefold. And that is much, 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 much more than we can do with defibrillation, that we can do in the emergency medical services, or what we can do in the hospital. It's much better than anything else.
In our last podcast, we were discussing the efforts made by IRCF in ensuring that AED is available all across India. Now, I understand the use of AED is quite prominent across Europe. Having said that, what do you think is the next step in ensuring AEDs are used efficiently? And this is from the perspective of the ENSURE study that looked at AED use in Europe. What insights did you learn from that? Was there any need for legislature so that every layperson is empowered to use an AED? In short, I'm asking you, what is the experience with the use of AED in Europe, and what can be done to ensure that AED used in the most efficient manner?
So in my country, we have a lot of AEDs around. Particularly in Cologne, we have about 200 AEDs since 15 or 20 years. And it is extremely seldom that lay people are using it, because lay people are always afraid of using AEDs. And if they are using AEDs, it took them a lot of time with a long duration of interruption of what is really necessary, which is cardiac compressions, to bring the blood with oxygen to the brain. So in my country, we recommend as a civic duty, check, call, and compress. Check, call, compress, check for signs of life, call the EMS, and compress and bring the blood again to circulate so oxygen can get to the brain and the brain cannot die. And only if there are 3 or more lay people on scene, someone should go and look for an AED. If you are alone or if you are only 2 people, please do CPR until the emergency medical service arrives, because in adults, in most of the cases, there is enough oxygen in the legs, in the gut, in the lungs that can help the brain to survive if this blood is just pumped by cardiac compressions to the brain. So don't run away and look for an AED. We recommend, and this is a little bit different in different regions of Europe, and also the AED density is different in different regions of Europe. So we recommend AEDs particularly for first responders. So if you're using an AED, it is, in my eyes, absolutely requested that you are trained to use an AED. Otherwise, you would lose a lot of minutes without cardiac compressions, and that would be detrimental to the patient. So AEDs, yes, all over the country for first responders or very well-educated laypersons. But laypersons who are not educated and never have used an AED, just do check, call, compress, and compress until the emergency medical service arrives.
What about drones used in CPR? Is that something that is catching up, or is evidence still lacking?
There is no evidence. We have some publications, just pilot trials from Sweden and from some few other countries. We also have a drone delivering AEDs in south of Germany, but we have not yet any scientific results. It is very nice because you can put it immediately on television. It's very spectacular, but outcome data are lacking. What I know from my clinical practice is you can, if you're doing good cardiopulmonary resuscitation, you can do it for 10 minutes without ventilation in adults. After 10 minutes, you should probably also ventilate, because then you don't have so much oxygen anymore in the blood. And if you're doing good CPR, you can do CPR for half an hour and then come with a defibrillator and defibrillate. It is enough You do not need to defibrillate within the first 2-3 minutes. The most important thing is cardiac compressions. The most important thing is blood needs to flow again to the brain, because there is no oxygen anymore in the brain, because the brain is taking 20% of the whole body oxygen consumption, but it's only weighing 1 or 2 kilos. And in the rest of the body, there is enough oxygen. So for the first, I would say 10 minutes, cardiac compressions is enough. And also in school children, we say, check, call, compress is the basis. And we teach school children in this, starting at 4 years of age until 14 years. And with 14 or 16 years old, we teach them also ventilation and the use of an AED.
World Restart a Heart Day is on October 16th every year. It is something that you have put your heart and soul in. Would it be wrong to say, by the passion by which you have executed it all these years, that it seems quite personal for you as a personal mission?
For me, there is, from my professional part of my life, there is nothing more important and nothing more touching than helping a person to get in better health or helping a patient to survive. I'm always totally attracted if I see patients that survive a cardiac arrest. And for me, it's the most important thing what we can do as doctors, nurses, or paramedics is someone is going to death and she or he can survive because we are doing cardiopulmonary resuscitation. And in developed countries, cardiac arrest is the 3rd leading cause of death. And the very positive thing, if there is a positive thing with sudden cardiac arrest, is that if lay persons start something before the emergency medical service arrive, it is not only associated with a 3-fold increase in survival, it is in many cases associated with good and neurologically intact survival in the cardiac arrest victims. And as compared to all other deadly entities, if you survive a cardiac arrest, you can live as good as before after the cardiac arrest. And this is totally different to all other deadly entities. And this is totally fascinating to me. And I would like to convince all people in the world, every single person in the world should know how to do CPR. And that is the reason why we should learn it in school, and we can start in the kindergarten. And if all people in the world would know how to do CPR, that would allow us to save hundreds of thousands of lives in addition every year, which would be a very positive impact in a world where at this time so many people died due to so different reasons that are really unnecessary, including all the wars that we have right now on our earth.
Thank you so much, Professor Böttiger. It was truly very inspirational speaking with you. Thank you for joining us. But before you leave, can you just share with us your experience from ILCOR? What was the key takeaway from it?
Well, I think the most important thing of this meeting is not so much the scientific outputs, but the most important thing is that we met again in person. For me, it was the first ILCOR meeting since COVID, and after having had so many virtual face-to-face meetings, it was good to see so many people working in the same direction again face-to-face, and that was the benefit of the ILCOR meeting. So I met people that I haven't seen for 10 years. I have met you guys from India. I have met the guys from the International Federation of the Red Cross and from all parts of the world, which was very important to me and which will strengthen our network for the future. The pure scientific output was not so high, and we would also be able to achieve this by virtual meetings, but knowing each other in person and getting something to drink with each other and getting out for dinner with each other is really strengthening the network, strengthening the worldwide collaboration, and at the end will help to increase survival in cardiac arrest patients all over the world in the next years to come. And it was great meeting you guys over there. I mean, this was worth the effort, I would say.
Thank you so much, Professor. It's truly a delight. Rakesh sir, perhaps you can share some insights.
So at this juncture, I must sincerely thanks Professor Böttiger and the whole ILCOR leadership, the European Resuscitation Council. They have been helping us, the Indian Resuscitation Council Federation, in various aspects. So we are really thankful to the leadership of ERC and ILCOR, along with other resuscitation councils as well, and especially Professor Böttiger, who has been guiding us on various resuscitation science aspect for the IRCF. So I sincerely thanks, and I'm sure that we'll be getting full support for development of the resuscitation science as well as the teaching training program across India in coming future. Thank you so much, sir.
Thank you so very much. I very much appreciated talking together with you today and in the last week and during the last years. So I'm very much looking forward to further fruitful collaboration. I feel very much honored to be part of this podcast, and cordial thanks and all the best.
Thank you, sir.
Thank you.
Thank you very much, sir. The way you have started this World Restart Day, meeting all the important politicians in Europe, it is definitely an exemplary act. And I think we have to also meet some of the members of the parliaments to mobilize this activity, like making it mandatory AEDs and everything. We'll follow your footsteps.
Thank you very much. I hope that what we have discussed during the podcast was okay with you and what you have expected.
We're more than happy. Thank you for joining in. Well, taking forward the conversation, this is to Dr. Mukul Kapoor. Sir, in the first volume of the journal released by the IRCF, we found your article on the history and evolution of CPR. Over the last few centuries, CPR has evolved from ill-defined and intuitive methods to a modern scientific form with well-defined standardized protocols. At this point in time where we stand today, tell us about how the science of resuscitation has progressed to what it is today.
Thank you very much, Megha, for making me a part of this podcast. Actually, I would like to begin with a line which I borrow from Professor Böttiger. And Professor Böttiger said that big things start small. And that is something very important, even in resuscitation, in all kinds of science. If you know, if you talk about Newton seeing the apple falling, it was just an anecdotal evidence at that time. But later on, evidence built up, science built up, and we came to know about gravity. Similarly, if you think about the beginning of anesthesiology, if you read about it, then it was basically the fun frolic parties where they used nitrous oxide, where Horace Wells and others saw people getting injured and not crying out or in pain, etc., which finally led to the development of the science of anesthesiology. The same story goes for resuscitation. Resuscitation, again, developed in a small manner. And by the time I started practicing medicine, it was very, very crude. I remember the days in which we used to give intracardiac adrenaline, used to use a lot of atropine, and we did everything our own way. That was the biggest problem with resuscitation. But over the last few decades, it has developed as a science. And what is most important in the development of resuscitation, I feel, in the development, in the progress of resuscitation, and in getting effective as a tool to save people, is the fact that it has got protocolized. I would give a lot of credit to the American Heart Association and the associated bodies, of course, the European European Resuscitation Council also, and also multiple resuscitation councils across the world, which have come together to modernize and protocolize resuscitation. Once you talk about the protocolization, let me say that it is the protocolization which has changed things. Maybe I was good at resuscitation, some other doctor may not have been good at resuscitation, whether I started the chest compression first or whether I gave adrenaline first or whether I give atropine to the patient or calcium gluconate, as used to be practiced earlier, the outcomes were not as great or as good as they should have been. But ever since, the scientists of all across the world have come together, ever since they've come together and made protocols and started issuing guidelines, things have changed. It is not only that a few people were involved in resuscitation earlier. I remember the days when no specialty used to be involved in resuscitation in India. I'm talking about in India in particular, that hardly anybody from other specialties used to be involved in resuscitation. It was purely a field which was handled by anesthesiologists. In the Western world, it was a field which was mainly handled by the cardiologists. But in India, it was mainly anesthesiologists who were handling the field. But over the years, everybody has got involved. It has been understood that each and every person has been involved, and that is why we needed to protocolize it. And this protocolization of resuscitation, I feel, is a big achievement. This is something which has helped evolve the science of resuscitation. It is more scientific today. Everything is explained by science. As Dr. Bernd Böttiger was mentioning about the meeting of the ILCOR recently, the science of resuscitation is discussed over many years in different kinds of workforces which are involved in developing it. And that is what is important. The discussion, the thrashing of each and every series which has been presented, the thrashing out of each and every original article which has been published, and extracting the science out of it. And that is what is today the field of resuscitation. I'm sure things are going to progress, even more. We are going to develop more and more automated ways of helping people do proper kind of resuscitation. Today we do manual chest compression, which is very effective, of course, but I'm sure very soon we'll have automated resuscitators, which will become even much more effective, which will improve outcomes even further. Maybe we develop drugs, maybe we develop new devices, maybe something immediately entering through the internal jugular vein. If your experts put something through the internal jugular vein, something like an artificial heart, things are going to develop, and the progress is always ongoing. Remember, science is the answer. And if you think about anything in a scientific manner, you progress. And that is how resuscitation is progressing over the years. And I'm very thankful to all the people across the world for putting the efforts together to do that.
Absolutely, sir. Science is the answer. I guess everything in science makes sense in the light of evolution. This entire journey is truly inspiring. Sir, in the same article, you've also mentioned about history of code blue. Code blue for anyone, for any layman, is synonymous with CPR. What are your thoughts on this and the role of code blue response team for in-hospital cardiac arrest cases?
Thank you, Megha, for touching this. This is a very sensitive matter as far as I'm concerned, code blues, because I feel, I'm very sorry to say, that most hospitals in our country do not have proper kind of code blue committees. This is one of our biggest failings in our country, despite the fact that Indian healthcare is very good in terms of economy, in terms of even quality. Our code blue teams are lacking. And code blue is something which we need to develop in a much better manner. We need to have better code blue establishment. I feel that ILCOR also needs to play a bigger role in devising exact guidelines for code blue. There are guidelines. I'm not saying they don't have guidelines. They definitely have good guidelines. But I think we need to define, we need to refine it and define things. Absolutely, each and every step of code blue needs to be defined in a better manner. We need to ensure that people get trained accordingly. Even in large hospitals, code blue teams are not assigned as a separate team altogether. They are generally a second duty given to people. Like even in my hospital, I would say we have also failed. The anesthesiologist on call is doing anesthesia call as well as doing code blue call. Similarly, the intensive care person is doing both of them together. I feel that is not what it should be. It is time that we have in every shift, people who are absolutely good at managing resuscitation, they should be members of Code Blue rather than people doing a dual role of this thing. I know it's very expensive to have so much manpower, but that is the need of the hour. We need so many people. We need lots of people. We need to save lives. If we need to save lives, you cannot have duplication of work. People should be assigned. If they are assigned to Code Blue, they should only be doing Code Blue and nothing else. That is something very important. And Code Blue teams should be given the due respect. I again feel that Code Blue teams are generally treated as normal doctors or technicians. They are not, they should be the heroes of the hospital. They should be treated like heroes. Anybody is it's something like an army general. If an army general walks in and he gets all the salutes, a Code Blue person should get all the salutes. The moment a Code Blue team comes back from a resuscitation, I feel everybody should appreciate them. There should be an announcement in the hospital that a Code Blue team did a great job today. They did wonderful. They resuscitated one person, and we should compliment them. This is something very important. Look after our Code Blue people, look after them well, and treat them well, and give them the due respect.
So, do you mind telling us about the prestigious International License Committee on Resuscitation, infamously called the ILCOR? What has IRCF's role been so far under the umbrella of ILCOR?
Megha, I would object to the term infamously. You should call it famously called as ILCOR. It is not
Yes, sir.
ILCOR is the backbone today of resuscitation across the world. It used to be one organization which used to get all the credit at one stage, or whether it was the American Association or the European Resuscitation Council, but the formation of ILCOR has made a difference. Over the years, it's basically a worldwide body of people interested in resuscitation. People have come together, and the science of resuscitation is essentially the same, whether it's India, whether it's the United States, whether it's Europe, whether it's Africa. The science of resuscitation will remain what it is. We need to resuscitate people after a cardiac arrest. That is what the science requires to do. And in case you want to do that, the thing to do is all the best minds of the world should come together, should sit down together and devise guidelines, draw out science from whatever research has been done, draw out good information from whatever has been published. And that is what ILCOR is doing. I don't say it is a political organization. It's not a political organization. Yes, it helps in getting people together. It may be, I would call it academic politics, yes. But what is more important is the functioning of ILCOR. ILCOR functions as a scientific body. It's a body which brings all resuscitation scientists together, and not only brings them together, uses them to devise guidelines which can be used by all associations, all resuscitation councils across the world. So I would say it's today the spine of resuscitation. It is not just a body, it's the spine of resuscitation science in the world today. And I think its efforts have been also recognized by the World Health Organization, which today identifies ILCOR as the body to talk to whenever resuscitation has to be talked about in the various WHO guidelines.
If ILCOR is the spine of resuscitation, I think we're speaking to all the cortex of resuscitation here, and we are truly honored. Rakesh sir, welcome back to our show. It's truly a delight to welcome you again. And congratulations on the official Journal of Resuscitation of the IRCF. There are many interesting articles in that, but one of them really caught my attention. It was point of care ultrasound used for resuscitation. So can you enlighten our listeners about the role of POCUS for resuscitation and what exactly is a restart protocol?
So when we talk about the resuscitation, there are many aspects because we have to something called reverse the reversibles. And there would be definitely some underlying pathology that would have lead to the cardiac arrest. And unless we correct that pathology during the CPR process, probably will not be able to have return of spontaneous circulation. So in this aspect, we have to use various tools. The clinical examination is one, the imaging is the second one. But now with the emerging role of point of care ultrasound, we can try to identify various pressing regions which could have led to the cardiac arrest in these patients. And that's why various strategies has been applied for using it. Way back it was for trauma patient for bleeding called FAST, then it became eFAST, and then it is emerging for various other pathologies starting from the cranium, from the ocular regions, from the airways, from the lungs, from the abdomen, and even for the embolism part. So this has been incorporated. I'm sure that with coming time, probably this tool will be one of the, you can say, the resuscitation person's stethoscope to look for whether there is some underlying cause that should be taken care during the resuscitation efforts.
I think ultrasound has become a very important part of our lives, isn't it? Another thing that has become a very integral part of our lives is smartphones. You can use it for most things in life, and it is endearing to think that smartphones can be used to save lives as well. One of your publications is on the use of smartphone app-based CPR for layperson. This is really interesting. So what are these apps and how does it help in CPR?
So I think this is because now we are very well conversant with using the mobile apps. Everybody has a smartphone and everybody is so comfortable using these apps for their day-to-day activities. So when we talk about the CPR related apps, it could be either used for teaching and training purpose, and it can also be used for real-time conduct of the resuscitation efforts, and the person can see on those apps and do it. And third, nowadays it is also being used for informing the centers for access to the, earlier it was telephone CPR, now it could be the app-based CPR, which can be supervised and the information regarding the patients can be sent to the nearest center. So this is what is the future. I'm sure that right now in India, even the IRCF will try to have its mobile-based CPR teaching training activities in near future. IRCF is working on it, and this will enhance the accessibility to teaching and training of the laypersons and also the paramedics in near future.
I'm glad you brought about accessibility. CRTC centers in India are striving to reach and teach as many as possible. But as you said, accessibility, scarcity, and affordability is a problem in India. I wouldn't say problem, but it is an issue in India. But do you think with the advent of artificial intelligence, does it help in any manner in resuscitation? Or how else is AI expected to be helpful with respect to training of CPR?
Right now, we probably do not have much evidence that how AI can be incorporated into teaching training. But yes, there has been some role of artificial intelligence in simulation training-based program, where the various aspects during the simulation activities can be now picked up by the artificial intelligence, and they can be re-emphasized for better training and better outcome. With regards to CPR, real-time CPR, we do not have right now data that in real-time CPR, how the AI can be incorporated into the system. It's near future. Let's see how it emerges. Probably, I think that it could help us to understand the red flags of a patient who is admitted and goes into cardiac arrest, how the patient responds, maybe for the prognostication. But I think we need more data, more research into this field for bringing its applicability into the resuscitation science.
Artificial intelligence has to wait as of now. And that brings us to the end of another episode of Resuscitation. We would love to hear your thoughts. Feel free to reach out and share your stories and experiences. Until next time, keep learning, keep saving lives, and remember, every heartbeat matters. Let's restart a heart on October 16th, World Restart a Heart Day. Catch you on the next episode. This is Dr. Manshat signing off from Resuscitation, the official podcast of IRCF.